Welcome. My name is Cassie Farrell. I'm the Customer Care Manager at Nehta. Thank you for attending our second webinar today, which is a joint webinar with APNA, and it's a how-to guide to the National eHealth transition to the National eHealth Record System. Thank you again for all those that attended last week's webinar. I'm hoping that there are some of the people from last week that are attending today, but I also am aware that there will be some new people on board. If you did attend last week's webinar, APNA do have the recording on their members' website, so you need to know your login details and then you can access the recording through there. Or alternatively, you can access it on the Nehta website, and we've got the links to the 4 providers website later on in the presentation for you. Without further ado, I would like to welcome you to Julianne Badenoch, who is the President of APNA, and over to you, Julianne.
Thanks, Cassie. Welcome and thank you all for attending the second of 2 webinars brought to you by Nehta and certainly proudly supported by APNA. My name is Julianne Badenoch and I'm the President of APNA, the Australian Primary Healthcare Nurses Association. I'm also a Clinical Governance Advisor with Nehta. Last week, many of you joined us for our first webinar introducing eHealth for primary healthcare nurses and in particular nurses working in general practice. This week we take a more practical journey with a how-to guide to use the National eHealth Record System. Last week I said my connection with the importance of eHealth goes beyond my national roles with APNA and Nehta. Firstly, I am proudly a grassroots registered nurse working in general practice in rural South Australia. And secondly, I'm the carer for an elderly mother. But thirdly, like all of us, I too am a consumer and well aware of my own health needs and the fact that they will increase in time, most likely. As I also said last week, I have a passionate belief in eHealth and for the need, if not the urgency, for eHealth to become fully integrated into our normal daily lives, both personally and professionally. Today we'll be bringing you that how-to guide to use the National eHealth Record System and the benefits of a connected healthcare community. Then we will explore the increasingly important role nurses working in general practice play in making eHealth work. I encourage you to take the opportunity to ask questions, particularly of my colleagues who are truly the eHealth experts. Well, what we know, APNA and Nehta have long recognised the important role nurses play in general practice, and in particular nurses' role with safety and quality and change and adoption of new systems. Looking at general practice in particular, nurses constitute a significant and certainly a rapidly growing part of the workforce, with almost 12,000 nurses employed in general practices across Australia now. What we know, nurses intrinsically have quality and safety as a core factor in the holistic care of their communities. We know nurses in general practice settings already play a key role in the maintenance of clinical health records. Care coordination, management planning, health assessment all provide perfect opportunities for updating and ensuring data accuracy and providing good incentives for general practices to ensure nurses have the time, the space and the opportunity to spend with clients. We know nurses also play a central role in childhood and adult immunisation, wound care and the delivery of other types of care which require ongoing documentation. We know many general practices regularly rely on nurses to ensure quality and consistency of clinical record systems. Data cleansing and quality coding will ensure good transfer of data with uploading of the documents that we use every day to eHealth records. Therefore, I believe general practice nurses in particular have the potential to be significant drivers and enablers in the transition, the implementation and the uptake of the eHealth record. Nurses can also do this by taking every opportunity to align eHealth literacy and uptake by consumers and clinicians whenever they can. Finally, I would like to reiterate, I know if we make a conscious effort to prepare and get on board now by investing the time up front and hopefully building it into our core work, I just know that we will get great benefits in the long term. However, enough from me, but before I hand over to Heather McDonald, Nehta Manager of Clinical Usability Program and Adoption, I'd just like to introduce one question that I'm sure people are very interested in. The PCHR review was released on Monday. There are recommendations in that have a few implications regarding the future of Nehta in particular. Are you able to have any insight into this and help us out here, Heather? Oh, we've lost Heather, have we?
Thanks, Julianne.
Thank you.
Tough to start with.
Yeah, right. First of all, I'd like to welcome everybody, and my name's Heather McDonald, as Julianne introduced me. I'm the manager at Nehta for the Clinical Usability Program and Adoption. My background is as a registered nurse, so this is quite dear to my heart. There's just a couple of things I'd like to say before I do answer that question, Julianne, and I will answer it. Last week, we had some polling questions, and I didn't stop to discuss them. This week we will be, and we're sending out a few polling questions shortly, just after I have responded to Julianne, and just to get a sense of where we're at, and then we'll get on with the presentation. Yep, so, well, first of all, I think we should say the budget was released last Wednesday, as we noted, and this time last week, there's 140 million for e-health across the country, which means we do have some capacity to keep working, which is good news. The review was released on Monday. Most of you will have read about it in papers or seen it yourself. If you haven't, you can download it off the Department of Health website, so you can read it for yourself. There's 38 recommendations. There's two that are fairly significant, I think, for us today. The first one is there's a recommendation. Well, what's going to happen now is there's consultation occurring to make a response to those recommendations from the government, from the Department of Health. So you may see Paul Madden might be at a place near you or one of his offsiders to get some consultation and feedback about the recommendations. Peter Dutton himself has said he'd like feedback, so if anyone feels passionate enough to respond, I think that's what they're looking for. And so there'll be the process will be, there'll be consultation around the recommendations, and then there'll be some recommendations put forward as to how to put the recommendations into practice. There's a couple of recommendations. The first one is the opt-out. You've probably seen about this. So this means that everyone will have a PCHR, so people won't need to register. I think the report suggests that this could happen by January 1 next year. I think that's probably a little optimistic, but nevertheless, I think having these sort of webinars are important because if it's opt-out, we're going to start needing to use it. So I think we need to get on with it and get going and get plenty of records into the system so that when we're encouraging people to use it, we can actually say, yeah, there's records there. So that'll have some implications. And of course, the other one is that the suggestion is that Nehta be dissolved and another e-health body set up. I think they're calling it the Australian Commission on E-Health or the Australian E-Health Commission. And Nehta was always a transitional authority. That's what the T stands for in our name. So I guess this was always going to happen. It was just a matter of when. But it can't happen overnight because Nehta is actually owned by the state and federal governments. So one of the stakeholders can't just make a decision and the rest say, goody-o. So there's a fair bit of work to be done to untangle the constitution and the ownership of Nehta. So in the meantime, since we've got some money and some work to do, we're all just working as normal, and we're expecting to make a difference into the community of e-health and get some actions happening. Now, I am happy if people want further responses. There's not much more to say. As I said, the report just came out. There's going to be a lot of consultation before anything really happens. So I think that's fine. Okay, so I think we can send out the questions and get on with today. So what did we learn last week? Okay, I'll just wait and see. Oh, that's good. So I learnt that I need to wait for the polls, as I'm going to do right now. Okay, so it looks like about half and half. So I'm just conscious of that. So I don't want to repeat too much that I spoke about last week, but I will recap.
if I can get the slides working. Okay. Okay, so what are we going to do today? I want to recap on last week. I want to resolve any actions. So if anyone's actually applied for something and need to get through it, I'll address that now and up front rather than later on. I'm going to recap on the benefits. I'm going to talk about how the workflow impact and what we can do to ensure there's not much workflow impact and how we can incorporate some of our eHealth uploading of documents into our current workflow, and then how to make it work for you. One of the things that we did last week was we addressed the eHealth Foundation. So we talked about the HPIO, which is your organisational identifier, HPII, which is your professional identifier. So that's what you get from AHPRA. Okay, I see there's another question. We've asked this reason about clinical information systems because one of the questions that came up last week was, could we register as a nurse in the practices? And I've got some screenshots of Medical Director because you can do that now. So I will talk about that. Best practice you can. And ZMed, I don't think you can register as a nurse just yet, but in their next release you will be able to. Okay. So we talked about having our own IHIs, which everyone's got, but it's about getting that sorted, and we'll go into further detail today about making sure your demographics match. We looked at the shared health summaries and event summaries. We are going to go into that much more today. Okay, did anyone upload a shared health summary? Ah, that's good. There's a few of you. And no one attempted and had problems. So I'd be keen for those who did, they might want to just say if they had any problems or how long it took them. All right, so let's get on with it. Okay, last week we talked about Medical Director and not being able to access it. So this is the screenshot from Medical Director where you can actually go into it. Now this is version 3.15.1, which I think was released about October last year. So you should have this, and I think there was a patch after this fixing up another problem, but anything later than 3.15.1 will have this screenshot on it. So that just gives you an indication how you can register as a nurse. Now if anyone's using best practice and don't know how to do it, just ring the helpline because that's where Kathy lives, and she or her team will send you out the screenshots for best practice. Okay, we got another. We've got another question. Okay, did anyone have any problems getting their HPII? And if you did, please ask the question on your private chat room, and we'll just see if there's something we can tell you now, because if you had a problem, someone else may have a problem in the future. If you didn't have any problems, that's fantastic. Okay, so let's get on to recapping on the benefits for nurses and eHealth in general. But one of the main things is there's less time finding and, okay, someone has I'm just going to interrupt this as I go, as I see. Somebody had to apply twice, but, okay. So the benefits, the key benefit is less time, and you don't have to call anyone else to get information. So you've got your information in your hand, so we can share between the silos. There's less duplication, and this is particularly important for the patients as well as yourself. So if somebody's had some blood tests, and you don't have to repeat them because they've forgotten them. There's efficiencies for sure. Some practices fax or scan up to 20 hours at a time. The continuity of care for the patient is they don't have to keep telling their story, and also they don't have to remember their medications, and particularly as we all get older, that's more problematic. You have more information. I think when people say that this is not a comprehensive record when we're talking about the eHealth record, right, yeah, because it's not because patients don't always tell you everything about their medical history anyway. So I think when patients are starting to, if we're suggesting that it's not a complete record, it's certainly better than what we've currently got. And I think that's why we need to sort of understand what the benefits are and start using it. Okay, now this slide here is come from the benefits framework. This is a slide which puts our benefits within the quality framework. So we've identified here what are the, and most of you would be familiar with the dimensions of quality, and I love these, so that's why I'm using them. So you can see how we can turn the quality aspect of this into improved treatment, improved preventative care, improved clinical handovers. Now, improving clinical handovers is key. This is where people's information gets lost between the hospital, community health, the GP, and back to the consumer themselves. So this is all absolutely one of the benefits. For safety, we've got improved treatment. We're going to have much better information to make much more informed decisions. We've got improved assessment. Access, increased choice. Now, something like increased choice might be when somebody's going to a different doctor. So say you go to your women's health doctor and then you go to your other GP for everything else, which, you know, some people do that sort of thing. But it means your other doctor can see that you've been somewhere else and what they might have done because they've put up an event summary, and then you don't have to sort of talk about it because it's already there, and it's just good to know that sort of information. Efficiency, we talked about the paper stuff, but also clinical efficiency. So you're not time wasting about ringing people and getting information about somebody. Population, increased innovation and enhanced workforce. You know, if you don't have to be scanning or doing things like that, you can actually be spending more time with your patients, which I think most of us would rather do than paperwork. Not sure why I'm not doing this so well today. I think my slides are a bit stiff. All right, so when we talk about the benefits realisation, we have to go across the whole spectrum. So we can talk about adoption and benefits. If you look at this slide and the chevron and we start with the capabilities, so what we're talking about when we've got a capability in eHealth, we're just talking about, do the vendors have compliant software? Do your practices have compliant software? So we count that at Nehta. That's one of our metrics. We know which vendors have produced the software. They go through their CCA conformance and they're able to hook up to the system. So that's a capability, then that's deployed to the practices and to you. Then we start to see about adoption. And you know, all of the stats for adoption are the numbers of providers that are registered with an HPIO. This was part of the EPIP payments. Number of consumers registered. They're very important adoption numbers. But while that's all good and well, getting everybody registered, we have to get people to use. So one of our early indicators of use is number of clinical documents. And as I suggested last week, you know, we are getting some more use in clinical documents, and we've got about, as I said, 20,000 shared health summaries, and I'd just like to say there was over 700 last week put up. So there's a bit of a spike happening now because I think now the review's done, the budget's out, it's here to stay, let's get on with it. So we can count those clinical documents, and that's one indicator of use. And we can count by the org type and all those sort of things. But then we get into meaningful use. So how do we know that what we're doing is useful? It's all very well, we send up a shared health summary. What the hell does that mean? You know, it doesn't mean much unless someone else looks at it. So that's what we mean by meaningful use. So we want you to look at the discharge summaries when someone comes out, and we can measure that. We want you to look at the event summaries. So it's the number of times a document is accessed by a different healthcare provider. So that's what we talk about when we say meaningful use. Then we know that people are actually viewing or looking at something. And then, of course, we get into the far end, which is, you know, health improvement and improved health outcomes. And hopefully that will translate into reduced unplanned hospital readmissions, reduced adverse drug events, and improved consumer experience. And as you're all well aware, it's quite challenging and difficult to measure improved health outcomes. But hopefully that's where we'll be. I don't know what I'm doing here. Okay, so just to talk about sharing, what I've got up here now is the record of the hospitals, a table of all the hospitals who are sending discharges and able to view. So we know most of you are all in connected GP practices, but if you're located anywhere near these public hospitals, you should be getting your discharges out. So 28 New South Wales hospitals are sending and they're viewing. There's some in South Australia. They're the metro hospitals. ACT has one, that's the Canberra Hospital. And Queensland, nearly all of their hospitals are connected for discharge. Now these discharges are going up and all the time. So we've got lots and lots of discharges that are currently up there. So if you've got a patient that's got a PCHR in any of these areas, look out and see if you can start finding the discharge summaries of your patients. Sorry. Okay, so now we want to talk about the impact to workflow. Because if you're starting to use this, how does it impact on your workflow? It's not working. I'm getting Okay. We did a time and motion study where we went into GPs and looked at their workflow, and in conjunction with some research, the average number of minutes a GP spends with a patient is about 12 to 13 minutes. And you can see on the screen what they do. But if we look down on the bottom of the screen, that last bar, you can see if a GP or if you as nurses in your consultation have a discussion with your patients so that you can see you need to talk to them about what it is and e-health and what this whole record business is about. You might want to do an assisted registration, and then you might make sure you've got clean data. And then I'll show you how to do the shared health, get ready for the shared health summary. So that takes a bit of time. So what people are saying is it may take up to 15 minutes, that first consultation. So how can we make that faster, and how can we get that just as part of our workflow? And that's what we need to think about. Okay, I've got this business sorted. Thank you. I apologise for the slides. Okay, so what can we do to get it ready? We can make sure that people that are actually able to use their CISs. There's so much in those CIS systems that you've got. We need to make sure the literacy of both you, yourself, and your GP and your practice manager and everyone you're working with is up to speed. So if you're the computer champion in your practice, run some classes, tell people how to use it so people are familiar with working around their system. It's cleanliness of existing clinical data. We'll go through the steps that are how to get clean data. Most of you should be familiar with this. It's part of your accreditation standards. Registration status of the consumers. If you can get the consumers registered before they go to you or before they can go to the doctor, that will be helpful. It saves that time. We need to have informed consumers. Now, many of you are working in areas where you've sent out a whole lot of information already to consumers about getting registered, so that's a good start. The assisted registration is in most of the CISs now, so you can use the assisted reg rather than what used to be there for Aspen and what some of the Medicare locals, although that's useful. But if you haven't got them there, then you can use your software system. And having a good knowledge yourself. All right, so I'll just recap on what we did last week, seeing half of you weren't here, about what the documents are. So a shared health summary is what is a summary of the person's health. It's not meant to be the full detail of what you'd have in your own clinical systems. It's just a summary. You have your allergies, you have your medications the person's on, past medical history, and what's happening at the moment. I think I've missed one, but we will go into it further. There's only 3 professions that can upload a shared health summary, and they are a registered nurse, doctor, or an Aboriginal health worker who's able to get registered with AHPRA. And the idea is that you're the nominated healthcare provider. So many of you working in practices will have patients that you do care planning for, and you do a lot of, you have a lot of continuity of care with those people. You, in fact, can be that nominated healthcare provider. It does not have to be your GP. If you're part of the care plan, you can be the nominated provider. An event summary is a document which is just a summary of that event, as it says. Anyone can upload this, or anyone who's got an HPII, so you have to be registered with AHPRA to have an HPII. So this would be, for example, you might be doing some wound care for somebody. If you're a community nurse, you might be visiting someone in the home for a period of time. So after you've finished that period of time, you would then put up an event summary to say, this is what's happened to the patient, you've discharged them. Someone might be on holidays and cut their feet on oyster shells, and they would go in for an immunisation, and that would go onto the event summary. So what we're trying to sort out in the systems, and part of our clinical usability program, is improving how we look at these documents and how they fit into the CIS. And we're having the document lists, so they'll bring down all the events that have occurred following the last shared health summary. So the nominated provider will have put the shared health summary up, and then when they see the patient the next time, they'll see that there's 3 event summaries there since they put it up. So then they can assess what's happened since they last saw them. And a discharge summary is coming from the hospitals or the emergency department. They send out discharges. So that's the same as it is now, except that it just goes up into the system. Okay, so how can we get the best? So what's important? One of the things that we've found and getting some feedback on is that your clinical information system has different demographics or different information about the patient to what Medicare does. And so it's causing some problems because there's a mismatch. So when you go to validate the patient's IHI, it comes back as a no match. So what can you do about this? You can be checking your demographic details within your clinical information system to make sure your family name's the same. And this might happen when you've got a William Smith, and he might be called Bill. So you might have him as Bill Smith, and his Medicare have got him as William. And sometimes this is why, and so patients may have already gone to get their PCHR registration at the Medicare office. So the Medicare office has the right details, but in your clinical information, so they'll come in registered with a PCHR, but your system still has a different Medicare data. So these are the sort of things you need to check, and demographic data, because it's an exact match with IHI. It's not a Medicare is an exact match. So you have to have the exact name and the exact address. I think we've done some change requests to make the address a little bit more flexible, but name certainly is. Okay, so that's an important thing. Okay, so what does data cleansing mean? When we say, oh, you know, we've got dirty data, I mean, let's just think about this for a minute. So these are some steps that need to be taken. So you need to, you know, archive all your inactive patients, remove your sample patients, merge duplicate patient records. So your Bill and William might have 2 records. You might have come in and you might have been William one day and Bill the next. So put those records together to make sure you've got a complete story about your patients. Maintain your recall lists. Update medications. So if someone's been on antibiotics ages ago, mark it inactive so it doesn't keep coming up when you're pulling the data out. And use the drop-down menus for your terminology. So free text should be limited when you're writing into these systems. You should, for diagnosis, use the drop-down menus because then they just all come up as the right text. So learn and how to use your tools. There's quite a few tools and many of you will be familiar with these. These are by no means comprehensive, but it's your clinical software search tool. You'll have the PenCat team tool and the canning tool. So they're all tools that help with data cleansing. And the RACGP has some good tips on their website. Obviously, because this is part of the accreditation standards, so most of you, I'm sure, would be familiar with this because you probably have to get your practices ready for accreditation. We're just going to do another poll. So, did any of you register for your own record? Okay. We've got more that haven't, but half and half nearly. So no one tried to and couldn't. So I guess it's important if you can do that, because then you know how to get your patients to do it. So you can, you're really clear that what are the documentation you need to register, and you can go on the website and find that out. And you know, there are some things that, yeah, there's another poll. Did you check with your organisations if they have an HPII? Oh, I mean. Okay, so if your organisation doesn't have an HPIO and you want to help them get one, there's assistance on our website. But the other thing, this is really important, and this is what you need to be doing with all of your patients. So if you're part of the care team, you might be part of your mums and bubs with your antenatal care, and then when they're coming back for their visits afterwards, chronic disease, have a look at their data, and with the patient's consent, review their information, which you will be anyway if you're part of the care team, and make sure their data is cleansed with using the tech terminology coding and get it sorted. And then if you're part of the care plan and you're able to send up a shared health summary, I'm sure your GP would be pleased if you're able to do that. But talk to your GP, but just clean up the data if you haven't got that arrangement with your GP and he wants to send up, or he or she wants to send up the shared health summary. Get the patient ready to do that. And then that just saves that consultation time with the GP, so they don't have to spend all of that 12 minutes talking about it. Okay, so what we're doing now is we've got a scenario to go through. So I'm going to show you how to do it. So this patient has past history of diabetes, osteomyelitis, and they've got a wound that's previously been debrided, but he's coming back in to have more wound care. So you're part of the team, and you're going to undertake a care plan consultation. So we want it to be suitable for you to prepare the data for either you to upload or your doctor to upload. And you're going to do some wound management later, and you'll send up an event summary. So prior to the appointment, you'll print out his demographic data. He's Robert. He could well be Bob. You know, who knows what he's got in his Medicare card. And you'll review his clinical record and have a look, remove duplications, and make sure that you've got the right demographics. Robert arrives, and he's already been registered for a PCHR, so you don't have to do the registration with him. So you're just checking that his demographic data will match. And then you're going to validate his IHI, but I'll just show you what happens here. So this is the steps we're going to go through. So you're going to conduct the care plan, and then you're going to prepare the clinical data to upload a shared health summary. And then 3 months later, you're going to put up an event summary, of which I'm not going to show you how to do, but we'll go through it with the shared health summary, which is the same process. So what I've done here is, this is on our website. It's a mock-up of a CIS. So this doesn't belong to anybody. So it's kind of just a mock-up of a CIS. So you can see here that circled, this is the current note. So what you'd do is you'd be writing in the notes. You can see the PCHR is green, and you can see down the bottom here that the, you can't see that, I have to get a dot. So down the bottom here, it talks about, it says here, HI PCHR validation complete. So most of the systems now just do a check in the background and come up telling you that. Some of the systems you've currently got that haven't been updated might have a big box here that says PCHR HI validated. But the latest releases on most of them are having it down the bottom here, just out of the way. Okay, so this is your past medical history. So while nurses can't prescribe or change medications, they can look at what the current medications are and see whether they're up to date. So if this person had medications that you know were ceased ages ago, you might just make them inactive in here. So you're reviewing the past medical history. And then we go to reviewing the medications to make sure the current ones are in there, the other ones are archived. Okay, so then you can see up at the top here, there's a PCHR button, and if you have a drop-down menu, this is very similar to the current CISs that you'd probably be using. You'd say Send a Shared Health Summary. So you can see there's a Send an Event Summary, so that would be similar. So you just press on that, and then you'd get a screen that looks like this, or something similar. So what you've got here is your system is getting ready to stand up the Shared Health Summary. So from this screen, you can see that everything's come up ticked that is in the system that is current. You can see depression and the drug that this person takes for depression. So what I'm showing you here is just to give you an indication that some diagnoses or medications can be kept secret or kept confidential. So they don't automatically go up. So when you think the system's pulling everything out of your CIS, if you've marked it as confidential in your system, and I think you probably already do that for some of your e-referrals, don't want to send everything across, that's currently you or the doctor can make that decision together about what goes up. And it's at this stage you might say to the person, oh, you know, maybe it's not so bad to tell people you've had some depression. And that's when you have that conversation. If it was about your plastic surgeon, I don't think you need to put that up. And this is what a Shared Health Summary looks like before it goes up to the system. And this is what it looks like when you pull it down. So this is curated with the information from your clinical information system and looking like it. So you can see down the bottom here where we've got this red here. This red writing is attesting that you are the nominated provider and the patient gives consent for this information to go into the system. So the patients don't have to give consent for event summaries or discharges. It's assumed if they've registered, they've given consent for it to go up. But a Shared Health Summary is a little bit different. They need to look at the content and agree with it. So they need to know what's going up in their system, and this is the Shared Health Summary, and this is the time here. So when you press upload, that means you've agreed with the patient to do that. Okay, there's one question. Okay, so most of you don't have assisted reg in your practices, or if you have, you're not the ones doing it. Okay. Okay, so that's a Shared Health Summary and just a brief overview. There are demonstrations on our website, and I'll give you the link to those in a minute. And we've got demonstrations for each of the CISs. So whatever CIS you're using, as long as it's one of the ones that we've got a contract with, you'll be able to have a look at that demonstration. Key other e-health activities that you might want to be doing is getting your assisted reg. Now, lots of practices, lots of the CISs have now got that within their tool, and there's a step-by-step guide on the website. The other thing is to use the Medicare Locals supported assisted registration, or you could just suggest your patients go down to the Medicare office and they'll help them get registered if they don't want to go online and do the registration. The provider portal we talked about last week, but I'll just recap on that. The provider portal is it's the portal similar to your consumer portal where you can access. Now, you can see your patient's records through that, but you can print, but all you can do is view. So you can't download and you can't upload any information, but you can view. So you might want to do this if you've got a laptop, not an iPad or an iPhone. You need to have your NASH. Okay, this is asking about your individual NASH certs, because one of the issues is you need an individual NASH cert to access the provider portal. So it's a bit tricky when you do it. It's not as easy as going through your CIS to see a patient's record. It's much harder because there's a bit of toing and froing and a few steps. But it's one of the recommendations in the review to make this easier. So I suspect there will be some work done with this over the next couple of years. But in the meantime, if you've got your individual NASH cert, you can have a go at it if you've got patients. If you encounter an issue, it'll come back as an error message. And I know some people have been getting a lot of error messages. Some of these are getting cleaned up via the PCHR system or for your vendor. So there was a few early hiccups, and I know they have improved. And so what you can do is send the error message to us at the Nehta customer care team, and we can triage it and help you with that. Or ring your vendor. It's probably best to ring your vendor first up and find out if it's a problem with the software, and then assume it's a problem with the if it's a problem with the system. Whenever you're sending any information, you must make sure you de-identify it. So if there's any information about a patient, just take it off, and I'm sure you're all fully aware of that, and the IHI. Again, IHIs can only be used for giving healthcare. So this is a really important issue about the regulations on IHIs. You can only use them for caring for a patient. So we can help you with the error messages as long as you don't transmit the IHIs. So how do you register for the provider portal? So you need your IHI, and then you can you're getting your NASH cert. Here, this is the information. All right, so how else can we help you? On our website, we've got this page, which is for providers. And so you can see there the blue box for providers, and this is where you need to go to get lots of information. So then you go into your software demonstration. So if you click on that blue box, this is what you get. And so you can see down the bottom there where you've got software tools, software demonstrations. So this is really useful, and it's also helpful if you're wanting to train people within your practice to go here. And I would strongly recommend you do. Now, if you're having any usability issues, so once you start using the system, you or your medical practice or your practice manager or anyone within your team, there is some feedback here. So you can either be ringing Cassie's team, or there's a form here, usability form, and you can send that to us. And we get that, and then we'll address your issue. One of the other things back on this screen, you'll see here training environment. So the training environment is something that we've been playing with and had available for about the last 6 months or so. Just before Christmas we launched it. So it's a training environment where we can load it up with whatever desktop application you'd like to use. And we've got 12 test patients there, and we can simulate uploading clinical documents, viewing and downloading. And we've got a simulated PCHR sort of system. So you can download, upload and do that match that. We're currently just working to expand this. But this was created predominantly for train the trainer. So a lot of the Medicare locals have been using it. But as we progress, you probably need to think about, if you're the expert and the champion, book a time and do it with your practice. It's all online, and you've got people will support you and help you get it ready. I'd strongly recommend you start doing it. So the customer care at Nehta, which is email or usability feedback. And we're still in business, and we'd like to support and help you. So what else do you need to do? Start your data cleansing. Start working out, you know, when you're going to be sending up a shared health summary, which part of the team, you know, if you're part of the team that do care planning, a lot of you are responsible for sending care plans. You should be starting to upload shared health summaries for those patients. And you can go to the demos. Okay, where to get help? There you go. Call Nehta 1300. And we've also added in this presentation some helpful links. These aren't all on our website, but a lot of them are, but they're also just your software has a lot of information. Best Practice has got quite a comprehensive website, as does HCN. So we're just giving you those links there. So if you have either of those softwares, go to their website.
They do have YouTube as well. There's YouTube as well. How to upload YouTube on how to upload.
So use resources that are available. Okay, thank you. So I see we've got a few questions.
Sorry, I just wanted to reiterate and say thank you to Heather for her presentation. I also wanted to thank you guys for being the eHealth champions in your practice. And I just wanted to reiterate that the previous webinar slides will be on Nehta's website, as well as the recordings will be on the APNA membership login page, so you'll need your login details. So both webinars, the recordings will be on the APNA website. We really want to help you on the eHealth journey. As Heather said, you know, we're in business, it's business as usual. It's about making this a meaningful system that will help you as practitioners. So I really highly, you know, suggest and please complete the exit survey, because that'll help us know how we can help you. My team is very knowledgeable on all things eHealth, so we're here for you. So we've got some questions. I'd really like to answer those questions, and then we'll hand over to Julianne for a final sort of final note. So let's just try and answer some of these questions now for you. Lorna's put a few questions in there, and Lorna, a couple of them are, so the health, will there be any, sorry, I'll just scroll up to her questions, and essentially she was asking, could there be free text or anything within the eHealth record? We've got those key products in there, so it's the shared health summary, discharge summary, and the eHealth summary, which, sorry, event summary, which will essentially be the products that you'll be using. At this stage, there are no releases to do anything else there.
Oh, hang on. Can I? The shared health summary doesn't have free text, but the event summary has a clinical synopsis part where you do write free text. There's an opportunity just to download straight from your progress notes, so you can just import it straight in, and otherwise you can do free text on it.
Thanks for that. So we've got some more questions.
Sean has also asked, what happens if I'm the registered care provider and then leave the workplace? If you're the nominated provider at that time, you're the nominated provider. If the patient comes back and sees somebody else, they then become the nominated provider unless they follow you to your next workplace. It doesn't make any difference. What the regulations have tried to do with the nominated provider is to stop people having dozens of shared health summaries from dozens of different peoples. So the idea is that the shared health summary is put up by somebody who knows the patient and is their care provider, so they can understand that there's proper medical history, they're on those drugs, they know them. So that's the idea of the shared health summary. Yeah, I'll just say as well that the Medicare officers are now Centrelink officers. I think they're all in one, aren't they?
Yeah. And a couple of people have asked the question about how do they get their HPII number, and that is through APRA. So you would you automatically have a number. You just need to give them a call, and they'll be able to provide that for you.
About the safety of the system, one of the reasons it's so challenging to register is because it's a difficult site. It's MyGov site, and I know we've had some media recently about how unsafe these sites might be. I did read somewhere saying, is anyone sick of everybody just, all these security consultants saying how unsafe everything is so they can get a gig? But I'm not sure that's true. But look, it's a MyGov site, it's the Medicare site. Medicare I don't think has been hacked. So it is safe, and I think that's why we should just appreciate that it is challenging to register so that we are safe.
Lorna also asked a question around getting notified about the discharge summary. Could you answer that question there?
Yeah, there's no notification for the discharge summary. What's happening in Queensland is they're going up to the PCHR as well as point-to-point. The point-to-point is coming later. If a patient's got a PCHR, it'll come up as being green. I might go back to that slide at the very front where we saw that. So you can see, whoops, you can see, and this is where, so if someone's come in and already registered into the practice and you don't know that you haven't sent anything up for them, and they've come up as green because it's gone away and validated in the system that they've got a PCHR and an IHI, you might look in there because they may have a discharge summary being sent up if they've come out of hospital. If you haven't, and then you might want to send up a shared health summary or get your practice to do so. Somebody's asked, can they apply for an HPII number even if they don't work in a GP practice? Everybody who's a registered nurse can have an HPII number. It doesn't matter where they work. When the HPII, if you work within an organisation, at the time of working within the organisation, that HPII is linked to the HPIO, so that when you're sending up documents, it's linked. There's all of that happening, so that there's an audit trail as to who sent it up through which organisation. But because you're registered, it's automatic that you get an HPII. Like, I'm a registered nurse, but so I can have an HPII, but I'm not linked to any organisation and I'm not about to start using it. I won't be registering for my NASH cert.
There will be some.
What about uploading? I don't know what GPMT. For those who have read the report, there's a question asking, what about uploading GP, MP, TCA? So I'm thinking that's the care planning processes. At the moment, the only clinical documents that you can upload are shared health summaries, event summaries, and discharges. These documents are in what's called clinical document architecture, CDA for short. So the reason they're in there is because, and we've got different levels of those documents, and the way they're created is that it's atomic data, so it goes into an atomic data store. So eventually what we want is what's called a consolidated view. So for each patient, all the data from each of the documents will be consolidated, and at the moment we can't do that because it's not all atomic data. That's why you don't want free text or PDFs going up. So that's what the planning process is. Now, obviously, one of the adoption barriers is people think the care planning, sending up care plans would be better than sending up shared health summaries. So I suspect over the next year or two that will definitely be looked at, and then if that's the situation, the care plans could well be created into the format to go up. Now, I'm not preempting that. There will be consultation and work done.
I'm just conscious of time, so I would over to Julianne to close off the session today.
That's a really good question about who. You don't need to update your HPII. It's all done. What you've got in your practice, if you go to a practice, there's what's called an RMO who is responsible.
Is it RO, responsible officer, and an RMO? Responsible
officer, and they're the people that deal with the HI service. So if you go to a new place, you'll tell them what your HPII is, and they'll link it to their HPIO. So you take your HPII with you, and link it to wherever you go's HPIO. And there will be someone within that practice or workplace that knows exactly how and to do that, and you do it through them, and they do it. They register you through Medicare.
If you need to know, please complete the feedback form. Give my team a call on 1300 901 001. We're more than happy to help you on your e-health journey, and thanks again for your time. Over to you, Julianne.
Okay, thanks so much, ladies. In closing, I would love to give another little plug to our national conference next week, titled Thriving Through Change. It's at the Hilton in Sydney. I'm very hopeful Nehta and e-health will feature along with certainly many international and national experts. Opportunities certainly abound to network and hear from your nurse colleagues. But also, APNA is now delivering workshops around Australia, and these are showcasing and leading discussion and education around nursing and general practice in particular, and certainly another opportunity to touch base on health. So please go to our APNA website, www.apna.asn.au, or simply Google APNA. So thank you again for joining us today. I do hope this has helped you better understand e-health and certainly the National e-health record, and in particular the vital role that we as nurses can and many already do play within e-health. And I hope it's given you a thirst to find out more and to connect both personally and professionally with e-health. And once again, on behalf of APNA and the whole primary healthcare nursing workforce, I want to thank Nehta and our colleagues Heather and Kathy, and most importantly, thank you so much for joining us again today. Please keep an eye on APNA's website via Nehta's website. So thank you once again, and I hope you've gained quite a bit from this, because I only have too. Thank you.
Thanks, Julianne. Thank you, everyone.
Thank you.
Thanks.